The topic of lecture is examination of dental patient, subjective and objective methods, basic and extra. Lecture outline, typical scheme of dental patient examination using subjective and objective techniques, main methods such as visual, palpation, percussion, probing, extra methods, in particular temperature test, X-ray test, electric pulp test, caries detectors, diagnodent, transillumination, and medical documents of dental patient receptions, dental chart. The extraoral and intraoral soft tissue examination is an essential part of any new patient examination. This examination must be performed thoroughly and systematically to ensure that no parts are missed. With experience, the examination will become second nature and can be done quickly, but at first it must be broken down into few steps. In general, methods of dental patient examination are divided on such two parts. Taking a history, it means subjective examination, during which the patient provides the doctor with all diagnostic information about itself, and objective examination, using basic visual examination, palpation, percussion, probing methods, and extra methods such as laboratory and instrumental. The examination starts as soon as the patient enters the dental operatory. The patient's general appearance may give clues to medical conditions. As the patient enters the room and during history taking, it is essential to observe the patient's general appearance, symmetry, gait, walk, mobility, skin, and even smell. During the history taking, note any facial asymmetries, lesions, or scars. Subjective examination fall in such categories. At first, it goes anamnesis, after that, collecting of demographic details, history of the present complaint, collecting of medical history, dental history, and family and social history. Initial patient interview and data gathering are vital to the initial examination. Initial data such as medical history, dental history, social history are commonly gathered through the patient questionnaire and followed by an interview. In this interview, there are a number of questions that should be answered, which include the following. First of all, it is necessary to find out the patient's chief complaint. This is a concise statement of a symptom or a group of symptoms for which the patient is seeking care at this moment. What brings you to the office today? And during this communication with the patient, necessary to find out patient's expectations from the treatment. What are your goals and objectives in our office? How may we help you? These only the few questions that doctor should uh, ask the patient. It is examples. During anamnesis or history taken, necessary to remember that this step in questionnaire needs to be tailored in a special way to suit the individual patient, but it is sometimes difficult to get a clear idea of the complaint. It is usually best to start with an open question. Medical jargon should be avoided, and even regular hospital attenders who appear to understand medical terminology may use it wrongly and misunderstand. Constant note taking while patients are speaking is undesirable. Questioning technique is most critical when eliciting any relevant social or psychological history or dealing with embarrassing medical conditions. So, effective questioning will support in collecting appropriately good information about anamnesis of life. Communication, it is another important quality of the dentist. The importance of communication skills and tailoring communication to the individual cannot be underestimated. The need to consider the patient is principal, be they a child, adult, or adult with special needs. It is important to make the patients feel comfortable during the appointment. Explain the steps that will be followed and the length of the appointment, and answer any questions that patients have. Many patients feel some anxiety at dental appointments. They may feel vulnerable, apprehensive about pain, or ashamed at the condition of their teeth. It is important to appear calm, organized, and competent, even if you do not feel this way at first. And of course, during communication, necessary to evaluate expectations from treatment. Good communication makes life easier by facilitating the building of patient rapport and trust, thus helping to reduce patient anxiety whilst enhancing patient satisfaction and compliance. All of this contributes to a better patient experience and an improved experience for the dental team, as well as minimizing misunderstandings and complaints. And here is prepared table with essential principles of history-taking technique. First of all, it is suggested to introduce yourself and greet patient by name. Put patients at their ease. Start with an open question. Avoid leading questions. Avoid jargon. Explain the need for specific questions. Assess the patient's mental state during communication. And assess the patient's expectations from treatment. Demographic detail, it is another step in collecting anamnesis of patient's life. The age, gender, ethnic group, and occupation of the patient should be noted. Such information is occasionally critical. For instance, an elderly woman with arthritis and a dry mouth is likely to have Sjogren's syndrome, but a young man with a parotid swelling due to similar lymphoproliferation is far more likely to have HIV infection. Collecting complaints. Next step. Frequently, a complaint such as a toothache suggests the diagnosis. In many cases, a detailed history is required, and sometimes, as an aphthous ulceration, the diagnosis can be made on the history without examination or investigation. If earlier treatment has been ineffective, the diagnosis should be reconsidered. In a table below is collected statements about collecting complaints about the history of the present complaint. At first, it is suggested to record the description of the complaint in the patient's own words. Next, elicit the exact meaning of those words. Record the duration and the time course of any changes in symptoms or signs. Include any relevant facts in the patient's medical history. Note any temporal relationship between them and present complaint. Consider any previous treatments and their effectiveness. Pain, it is that symptom that usually makes patient to come to the dentist. Pain is completely subjective, and when physical signs are absent, special care must be taken to detail all its features. Especially important are features suggesting a dental cause. A fractured tooth or a cusp, dentinal hypersensitivity or occlusal pain are easily misdiagnosed. In listed here table, you can find typical characteristic of pain. So when it goes about collecting complaints about pain, we need to understand that type of the pain can be ache, tender, dull pain, throbbing, stabbing, electric shock. These terms are limited, and the constancy of pain is more useful. Severity of pain can be mild, it means managed with mild analgesics, moderate, unresponsive to mild analgesics, and severe, those that disturbs to sleep. Duration of pain, time since onset, duration of pain or attacks. Nature, continuous, periodic, paroxysmal. If not continuous, is pain presence between attacks. Initiating factors. Any potential initiating factors should be outlined. Association with dental treatment or lack of it is especially important in eliminating dental cause. Exacerbating and relieving factors. So dentists should record all and note especially hot and cold sensitivity or pain on eating which suggests a dental cause. Localization. The patient should map out the distribution of pain if possible. Is it well or poorly defined? And referral. Try to determine where the pain could be referred or irradiated. Medical and social history taken, next step in subjective examination of the patient. Medical history is important as it aids the diagnosis of oral manifestations of systemic disease. It also ensures that medical conditions and medication which affect dental or surgical treatment are identified. Are there pertinent medical conditions that need to be considered prior to treatment? For example, replacement of joint or anticoagulant therapy. And does the patient have any systemic conditions that could contribute to their current disease state? For example, uncontrolled diabetes. All of this should be found out during communication with the patient. Obtain a complete list of medications and analyze these medications for drug interactions, contra-interactions, and interferences to the therapy, at least necessary to collect medications from the last months the patient took. Any drug, food, or other allergies must be obtained and recorded. Obtain a social history of tobacco use and alcohol abuse, as tobacco use contributes to periodontal health. Discuss and record patients' nutritional habits. So these are critical questions that should be discussed with the patient during collecting of medical and social history. Family and social history, next step in questionnaire of the patient. Whenever a symptom or a sign suggests an inherited disorder, such as hemophilia, the family history should be elicited. Ideally, this recorded as a pedigree diagram noting the proband, presenting case, and all family members for at least 3 generations. Even when no familial disease is suspected, questions about other family members often usefully lead naturally into questions about home, circumstances, relatives, and social history, which can be revealing if, for example, psychosomatic factors are suspected. Dental history. Discuss your experience with previous dental care. Has the patient been exposed to preventive dentistry before? How often does the patient brush and floss their teeth? Has the patient had previous periodontal care? If so, what and how often have they been seen for periodontal maintenance in the past? How long has it been since their last periodontal maintenance visit? A periodontal history should be obtained, including history of bleeding gums, changes in tooth position, tooth pain, halitosis, and reasons for previous tooth loss. The final step final step in communication questionnaire of the patient. It is to assess daily oral hygiene habits. Observation of the patient's oral hygiene techniques is always done before doing periodontal charting. It is an essential step. Ask the patient to demonstrate toothbrush and flossing technique so that you have a baseline of the patient's dexterity and knowledge of their home care techniques. Ask about the frequency of the patient's home care habits and what the patient uses to maintain their oral health. This step is critically important in knowing your patient's understanding and use of dental hygiene instrumentation. It is critical to do this prior to the intraoral examination so that a baseline of patient home care is obtained, and as the examination is being done, the findings can be related to what was visualized when the patient demonstrated their techniques. Hygiene instructions should follow the completion of the examination. Next part of dental patient examination, it is objective examination. It is important to record if the soft tissue is within normal limits or not. If there is an abnormality, further details are noted, such as type of abnormality, size, color, location, surface texture, and consistency. A good knowledge of normal anatomy and common variations of normal is essential to determine if a structure is within normal limits or abnormal. It is also worthwhile to use the correct terms when referring to different regions of the oral soft tissues to facilitate communication with other dental professionals. So, objective examination starts from the clinical examination, such as extraoral. So, during extraoral examination, symmetry and profile are assessed at the first time. Symmetry of the face It is the correspondence of the left side of the face to the right side of the face. Increased development of lagging one of the parts a symptom of existing dental pathology or risk factor for its development. Assess the symmetry of the face as well at the head and neck region. These can be done if the patient is sat upright in the dental chair. Most of us have some asymmetries, but significant asymmetries on comparison of one side to the other should be noted. This asymmetry may be bony or soft tissue in nature. It may be acute or chronic, or it may be secondary to previous surgery, an example, a tumor resection or cerebrovascular accident. It may have occurred following injury, such as a fall, and the patient presents to the dentist with dearranged occlusion and facial asymmetry due to a mandibular fracture. Dentists should pay attention to the nasolabial and chin folds. They can be smoothed or increasingly visible. The reduction of the lower third of the face is associated with a decrease in the height of the bite due to its pathology, for example, deep bite or abrasion, tooth loss. Enlargement of the lower third of the face is observed with an open bite. The patient's exposed skin should also be examined. Check for any skin lesions, scars, or fistulas. Healthy skin is smooth, elastic. It is not dry or flaky. It can be grasped and folded. If petechia, ecchymosis, or hematoma are seen, then further information should be obtained from the patient about bleeding problems or medications such as blood thinners. If the patient's skin appears yellowish, more information is needed about possible jaundice or liver problems. And actually, here on these photos, you can see skin alterations, such as a cutaneous lesion of discoid lupus and erythema on the face due to lupus erythematosus. Eyes, it is another entity that should be inspected. Dentists should observe eyes for any abnormalities. Yellow sclera is associated with jaundice and may indicate an undiagnosed case of hepatitis A or B or other liver dysfunction or blood disorders. After visual examination, we can continue with palpation. Palpation can be done of lymphatic nodes. So the lymph nodes in the head and neck area should be palpated gently to look for tenderness or enlargements. The submandibular, submental, and cervical chain of lymph nodes are usually examined. Normal lymph nodes are either not palpable, or you may feel a lymph node that is the size and shape of a small pear. These are mobile and non-tender. Abnormal lymph nodes are generally larger, fixed, and may be tender. If an abnormality is noted, the number, size, consistency, tenderness, mobility, and location should be noted in the chart. Tenderness of the lymph nodes generally indicates inflammation or drainage of infection. Cancer metastasis to a lymph node is often a fixed, non-tender, firm enlargement. Lymphoma is another possible cause of non-tender enlargement of lymph nodes of the neck. Palpation of lymphatic nodes is done bimanually. On this photo, you can observe palpation of occipital nodes. Auricular lymphatic nodes is palpated bilaterally using the pads of the index, middle, and ring fingers. Preauricular and post-auricular lymphatic nodes palpation. Cervical chain of lymphatic nodes. Palpate the nodes medial to the sternocleidomastoideus muscle using a bidigital technique and the nodes posterior to the muscle with a bimanual technique. So here you have the palpation of the posterior cervical nodes and palpation of the anterior cervical nodes. Supraclavicular lymphatic nodes. These nodes are examined using digital compressions just superior to the clavicle. Submandibular lymphatic nodes. Palpate the submandibular nodes by pulling or rolling the tissues under the chin up and over the inferior border of the mandible. Ask the patient to touch the roof of the mouth with the tongue. Pressing firmly against the roof will allow you to assess the muscles and any pathology associated with the submandibular lymph node areas. And here you have the technique of how to provide palpation of submandibular lymphatic nodes. It is done with a cupped hand as shown on a figure. Submental lymphatic nodes palpation is done with a digital palpation of one hand. It is necessary to press on the submental area as shown on the figure. Salivary glands. The next most common extraoral mass that may be found on palpation is a salivary gland neoplasm. Parotid neoplasms in particular are best detected by careful palpation of the preauricular skin. Extraoral palpation of the submandibular glands can often reveal enlargement and tenderness. However, bimanual palpation frequently is more effective. Palpation of submandibular glands. Normally, these glands should not be palpable. Induration and pain could be signs of infection, blockage, immune system disorder, or neoplastic process. In addition, non-tender parotid enlargement may occur with alcoholism, diabetes, Sjogren's syndrome, eating disorders, HIV infection, and various malignant and non-malignant states. Temporomandibular joint, TMJ. Is checked to find out any crepitation, clicking, and popping of the temporomandibular joints. And actually, it is the most easily detected by placing the tips of the little fingers in the external auditory canals and having the patient perform a series of excursive mandibular movements. So this photo shows you appropriate technique of checking TMJ. At first necessary to position the fingers on the TMJ joint and then ask the patient to open and close mouth slowly. If there are any problems in the course or clicking or popping, it can be a signal of a disorder that possibly can be the result in a bruxism, for example. Nerve trigeminal. The most likely cranial nerves a dentist may need to examine are the trigeminal and facial cranial nerves. Infections of the mandible, including osteomyelitis, may present with altered sensation. Objective assessment and documentation of the neurology will be important as infection, trauma, fractured mandible, iatrogenic following surgery, and malignancy are all possible causes of altered sensation. So palpation of nerve trigeminal points on the face skeleton is done bimanually. Palpation of these points is effective in differential diagnosis of pain origin, tooth origin, or neuralgia. In a case of neuralgia, these points will be painful. And just to refresh your knowledge about the anatomy. So here is located supraorbital foramen, foramen infraorbital, and foramen mental. All of them is located on one imaginary line that is crossed through the pupil of the eye. Lips. It is another anatomical structure that should be checked both visually and by palpation. So vermilion border should be checked for even coloring, symmetry, sharp demarcation between the skin and the lip vermilion, blurring of the edge of the vermilion can be seen in actinic cheilitis. Record if there are any abnormalities such as hyperkeratosis, ulcers, or pigmentation. Check the corners of the mouth where redness and small fissures may indicate angular cheilitis. Technique of checking. With the mouth 3/4 closed, gently grasp the lower lip between the thumb and the first finger of each hand and avert the lip. This can be done to the lower lip and then the upper lip. Record any abnormalities of the labial mucosa such as polyps, scars, or ulcers. Scars inside the lower lip are seen frequently as a result of trauma in a child period. So these photos shows you bidigital palpation of the upper and lower lips. We have finished with extra-oral examination and moved to intraoral examination that is divided in two parts: examination of the vestibule of the oral cavity and examination of the oral cavity. As with any other portion of the physical examination, the examination of the oral cavity should be conducted in a uniform and consistent manner. For many individuals, the examination of the oral cavity is a clinical skill that is acquired only through repetition. Examination of the oral cavity can only be performed adequately with good light, mirrors, and compressed air, or other means of drying the teeth. If viscid saliva prevents visualization of the tissues and teeth, a rinse with sodium bicarbonate mouthwash will be helpful. So here I suggest, in this diagram, I suggest to you tips for intraoral examination. First of all, it is important to take a few moments to conduct a general inspection of the whole oral cavity before directing one's attention to a single tooth. Although the patient could point exactly to a particular tooth that is causing the pain. A general understanding of the patient's oral health status often has a great impact on decision-making regarding the possible treatment of the acute problem. And finally, knowledge of normal anatomy of oral cavity structures is important in decision-making process and will provide clues to the likely diagnosis. Intraoral examination starts from the examination of the vestibule of the oral cavity, and in the vestibule of the oral cavity can be visualized frenulum of upper and lower lips, and gingiva, and of course occlusion. To check frenulum, it's necessary to avert lips. If frenulum is attached not in appropriate position, it can lead to diastema or tremor. In healthy individuals, the labial mucosa is smooth, soft, and well lubricated by the minor salivary glands. But do not be confused if patients who come to the dentist office due to anxiety possibly could have dry mouth. But this is not a disease. It is only the symptom of anxiety, of nervous. And definition here I have prepared for you. So what is vestibule of the oral cavity? It is the region between the lips and cheeks and the teeth. The fold of tissue created by the vestibule between the lip and teeth is called the maco-buccal fold or maco-labial fold. Here it is located, here as well. So in the vestibule of oral cavity, the dentist can check labial mucosa, frenulum of lips, gingiva, and state of occlusion. Occlusion is defined as the way the teeth meet when the lower jaw mandible and the upper jaw maxilla come together. It is how the teeth contact in any type of functional relationship. Physiological occlusion is desirable as it allows oral functions to operate properly, provides the best aesthetics, and is helpful in the prevention of disease. Anytime normal occlusion does not occur in the mouth, it is termed malocclusion. Malocclusion can have an effect on dental diseases, chewing, speech, and aesthetics, especially facial profile, and other functions of the oral cavity. Malocclusion can occur for a variety of reasons. These include, but are not limited to, heredity, trauma, diseases, and habits. An example, thumb sucking. This diagram shows you different types of occlusion. So broadly, they are categorized in this way: physiological, pathological. Physiological can be orthognathic bite, straight bite, physiological progeny and prognathie. And pathological can be open bite, deep bite or overbite, cross bite, and of course mesial and distal bite. How to determine occlusion? Occlusion is examined when dental arches is closed. There are physiological occlusion, such condition when person can normally bite, eat, articulate, and pathological occlusion that do harm in patients feeding and articulating. Occlusion is checked by asking patient to swallow saliva first and after evert lips, and dental arches should be closed. And then the dentist can uh, check the condition of the bite. Gingiva. The normal gingiva is coral pink and firm. The gingiva adherent to the tooth is called the marginal gingiva. It is continuous with the attached gingiva that covers the alveolar process. The attached gingiva is red, smooth, and shiny. And normal condition of alveolar mucosa and gums is such they should tightly overlap the tooth neck. To check gingiva is used bidigital palpation. Dentists as well should note color, tone, texture, architecture, and macrogingival relationships. If gingiva is diseased, it can be in the form of gingivitis. So here you can see hypertrophic gingivitis. And hypertrophic gingivitis as a result of adverse effect of some drugs, for example, anti-epileptic, calcium channel blockers, immunosuppressants. The next, what should be examined inside the oral cavity is soft tissues, buccal mucosa. Examination of the buccal mucosa is most easily accomplished by having the patient partially open the mouth, followed by a stretching of the buccal mucosa with a mouth mirror. Such anatomical structures can be seen on the buccal mucosa, such as Stenson orifice, orifice of the Stenson duct. It is duct of the parotid salivary gland, and linea alba. Do not misdiagnose these anatomical structures with frictional hyperkeratose due to habitual biting of the buccal mucosa or due to some leukoplakia areas. By the way, here you have the pathological element. It is area of hyperkeratose. Whithem stria here is visible. It is symptom of lesion planus. Another entity that is examined, it is heart palate. The heart palate is keratinized and covered by a series of fibrous ridges, arruga. The mucosa overlays a number of minor salivary glands. The heart palate, similar to the attached gingiva, normally is less pink than other oral mucosal sites because of its increased keratinization. Here it is distributed minor salivary glands. And pay attention to the normal anatomical structure, tori. Actually, it does not do any harm to the patient except if there is supposed to be prosthetic treatment. If such is present and prosthetic treatment is going to be done, so surgical operation is done to cut the tori. Soft palate. On a soft palate, to check the soft palate, the patient should say ah, and the dentist can check the vibrating line, tonsillar pilars, tonsils, and oropharynx. For any abnormalities, any plaque, redness, and so on. So tongue, it is the mirror of the health. The dorsal surface of the tongue is most easily visualized by having the patient protrude the tongue and attempt to touch the tip of the chin. But alternatively, the tip of the tongue can be grasped by the fingers with a gauze sponge, and the dorsal surface of the tongue should be uniformly covered by numerous hair-like filiform papilla that as is shown below. During tongue examination, the dentist can observe some lingual varicosities, and this can be a symptom of cardiovascular disease. As well can be observed geographic tongue or erythema migrans, the population of the tongue in one area. Drug reaction as well can be observed on the lateral border of the tongue. Dentists can as well observe signs of nutritional deficiencies and immune dysfunction. Atrophic glossitis in a patient with pernicious anemia. Mucosal atrophy appears as smooth, bald areas without lingual papilla on the dorsal tongue. A small quantity of Candida fungus is naturally present in the mouth and digestive tract of most individuals, and it does not usually cause an infection and result in symptoms. However, changes in the oral environment under certain circumstances can cause the fungus to multiply and lead to the presentation of oral thrush. Be aware about ulcerations on the lateral border of the tongue, because lateral border of the tongue, it is a favorite place for development of oral cancer, and it accounts approximately 3% of all cancers. Both the ventral lateral surface of the tongue and the floor of the mouth are common sites for intraoral squamous cell carcinoma, and this is considered to be the most aggressive type of oral cancer. For this reason, the index of suspicion for soft tissue lesions should be heightened, including otherwise innocent appearing red or white lesions, unless convincing history and compelling clinical evidence. Biopsies should always be obtained from chronic alterations and obvious masses to rule out the possibility of premalignancy or malignancy. So chronic trauma to the lateral border of the tongue possibly can lead to malignization. Floor of the mouth. It is necessary to visualize all area of the floor of the mouth and palpate bimanually, both visual examination and palpation. Be aware that on the floor of the mouth there is such anatomical structures as Varton's ducts, and floor of the mouth together with lateral border of the tongue, it is two favorite places of localization of oral cancer. Examine the floor of mouth using direct vision and mouth mirrors. Place one index finger of one hand in the floor of the mouth, lingual to the molars. Place the index finger of your other hand to the skin of medial to the patient's mandible, inferior to your intraoral index finger. Using a gentle up and down motion, palpate the submandibular gland and move your fingers forward to palpate the sublingual gland and floor of mouth. This examination should not be painful, but it is a slightly odd feeling, so the patient should always be informed before starting this examination. When it goes about any examination, it is necessary to remember about normal structures, and actually here I put this photo with normal structures in the floor of the mouth. You can find here lingual frenum. It is a primary soft tissue attachment of the tongue to the floor of the mouth. Over-attachment of the frenum may result in speech impediments, so-called tongue-tied. The orifice of the Varton ducts, which are located at the base of the lingual frenum, appear as two bilateral punctate structures. Mucous saliva can be expressed from the ducts with bimanual palpation of submandibular glands. Squamous cell carcinoma on the floor of the mouth. It is the 13th commonest cancer worldwide and the most aggressive one that gives metastasis and eventually can lead to death. Leukoplakia can be observed as well in retromolar area or on the alveolar ridge. The most important statement in examination of oral cavity: visualize all areas, not only that single tooth that patient indicate. There are several types of oral mucosal lesions that may cause pain and which may be difficult to differentiate from odontogenic pain. For these and other reasons, oral soft tissues must be carefully investigated in all patients complaining of some kind of discomfort in the oral region. Investigation is carried out in a good light by direct visual observation and with a mouse mirror. Tenderness to palpation of the mucosa and other oral soft tissues is also investigated gently using the fingertips. Ulcers and herpes are frequent causes of oral pain and may not always be easily identified and located. Wounds and lesions caused by dental procedures and materials such as monomeric resins, mechanical trauma, and allergic reactions are also typical causes of oral pain. Although infrequent, primary or secondary lesions of several diseases of the oral cavity and other regions of the body may be found in the oral cavity. Biopsy and consultation with oral surgeons and pathologists must be done in all cases where there may be uncertainty as to the etiology and type of the findings. And breathe. So, halitosis. It is unpleasant odor from the mouth, commonly referred to as bad breath. Halitosis can be caused by infections such as caries and periodontal pathology, chronic gastrointestinal disturbances, liver failure, diabetic acidosis, and so on. The final part of intraoral examination, it is examination of teeth. Examination of teeth should be the final part. Clinical examination of the patient's teeth begins with a general assessment of the health status of the dentition. Points of interest include number of missing teeth, number and size of fillings and other restorations, hygiene conditions such as a plaque and gingival bleeding and occlusion. Here you have tips for dental examination. So any number of developmental defects of the teeth may be apparent: partial anodontia, supernumeraries, missing teeth, can be found in a variety of inherited disorders. Gross decay of the occlusal surfaces of the teeth usually appears as a discolored cavitations and represents the sequel of poor oral hygiene. Decay involving the interproximal surfaces may not be clinically apparent without the aid of dental radiographs. The decay at the gingival margins of the teeth adjacent to the attached gingiva may be the first manifestation of xerostomia. Root surface caries are also commonly observed in geriatric patients with gingival recession. As a minimum, the standing teeth with a summary of their periodontal health caries and restorative state should be recorded. Tooth wear should be checked for parafunction of muscles. Dental examination should be thorough, both for the patient's sake and for the medical legal reasons. When dental pain is a possibility, full charting assessment of mobility and percussion of teeth are necessary, and further dental investigation will probably be required. We have finished with intraoral, extraoral, intraoral examination, and now in detail I would like to stop on the techniques of how to provide main methods of examination. And to refresh your knowledge, I will stress once again. So the main methods of examination are such: visual examination, probing, percussion, and palpation. In oral cavity, the most typical disease that can be observed, it is dental caries. Long before the caries actually reaches the pulp, bacterial antigens from the lesion may invade the pulp through dentinal tubules and stimulate an inflammatory reaction in the pulp. Teeth with caries extended into dentine are always potential suspects from an endodontic point of view. Dental caries can be checked both by visual examination and by using probe. So, probe is a necessary tool in searching for secondary caries together with the bite-wing radiographs. It is important to remember, however, that deep caries does not automatically cause permanent pulpal damage. Other additional investigations must be undertaken in order to make the diagnosis. Large restorations are always an indication of potentially harmful early irritation to the pulp. The typical reason for restoration are caries and dental trauma. In addition, restorative procedures themselves may cause physical damage, for example, vibration, increased temperature, or chemical damage to the pulp. The effect of irritation to the pulp during restoration may have been exacerbated by decreased circulation in local anesthesia where the vasoconstrictor has been employed. Large restorations often make it difficult to obtain information on the status of the pulp. Electric pulp testers with special narrow tips may be useful. Carbon dioxide ice-cold test has also been reported to work in teeth with a prosthetic crown. Rarely, it may even be necessary to make a test cavity through the restoration into dentine to test the pulpal reaction to stimulation. Attrition, abrasion, and erosion. All of them create a situation where enamel is gradually worn away, revealing the underlying dentine. And this pathology is as well typical during conventional examination of the dental patient. It seems, however, that if the wear process is not very rapid and if the local hygiene conditions are good, the pulp-dentine complex often manages to protect itself against microbial invasion. Key factors in pulpal protection are the formation of secondary dentine and perhaps most importantly, production of mineral deposits in dentinal tubules that effectively inhibit bacterial invasion. Fractures extending. Fractures extending into the dentine always cause some irritation to the vital pulp. If the fracture is not accompanied by a continual microbial stimulus, then pulpal reaction will be mild and temporary, unless the fracture is caused by an excessive force that has also damaged pulpal circulation. Microfractures as well, it is the reason why patients come to the dentist. Hypersensitive dentine can be found in any tooth, but it is most frequent in upper canines and all premolars. Hypersensitive dentine shows great individual variation in reactions to irritation. Often a blast of air to the buccal cervical area of the tooth causes a typical reaction of sharp pain lasting for up to a few seconds. Also, touching the area with an object, for example with a prop, may cause pain. Swelling and abscesses is usually caused by an inflammatory process stimulated by microbial irritation, sometimes by allergic reaction or mechanical trauma. For example, biting trauma onto buccal mucosa. An abscess is caused by microbial irritation. It is most common in connection with acute apical periodontitis. But nevertheless, not only endodontic abscesses are typical, but also periodontal abscesses can be found in the oral cavity. Another finding that a dentist can check during examination of the patient, it is presence of sinus tract or fistula. Sinus tract of fistula, it is a symptom of exacerbation of chronic granulating apical periodontitis. Always when fistula is detected, a fistulograph must be taken to localize the origin of the infection. Periodontal infections, gingivitis, marginal periodontitis, and periodontal abscesses are frequent causes of oral discomfort. They rarely cause sharp or strong pain, but because of the great variation that patients show in their reactions to the pain, a periodontal origin of symptoms must always be carefully considered. Discolorations. Discolorations can be caused by a variety of external and internal factors. Localized single discoloration is usually caused by local pathological or iatrogenic factors, some of which indicate possible pulpal involvement. Dental trauma causing bleeding in the pulp can lead to staining of dental hard tissues. The staining usually begins as a pink-red discoloration that gradually turns gray. In the previously root-filled teeth, discoloration may be caused by necrotic tissue remnants in pulp horns, silver-containing root canal sealers, possibly other chemicals from sealers, root-filling cements containing resorts in formalin. All of that can cause discoloration of the tooth structures. So we right now discuss sensitivity to percussion. So percussion, it is another method of examination, main method of examination. It can be vertical and horizontal. Sensitivity to percussion is tested both vertically and horizontally. Several teeth must be tested in random to get an understanding of how the patient reacts. A mirror handle is used with only slight force to try to elicit a possible reaction from the patient. Sensitivity to vertical percussion is a sign of apical inflammation that is typically caused by acute apical periodontitis, but may also be caused by occlusal interference, vertical root fracture, and rarely also by pulpitis. A negative test result does not necessarily mean the absence of inflammation. And sensitivity to horizontal percussion can be caused by marginal periodontitis, lateral periodontitis, or vertical root fracture. However, the results of percussion tests must always be interpreted with caution. Here you can see vertical percussion and horizontal percussion. Palpation test is performed with the forefinger applying slight pressure to the gingiva and mucosal tissues overlying the root. Palpation is done in order to find increased sensitivity, tenderness, soft or hard swelling, and crepitus. As with other tests, several teeth must be inspected for comparison and reference. Increased sensitivity to palpation at the tooth apex is a sign of apical inflammation, but a negative result does not rule out the possibility of inflammation. In most cases of apical periodontitis, the palpation test is negative or only vaguely positively. Tooth mobility. It is tested by holding the crown tightly with the forefinger and thumb and trying to move the tooth in both horizontal and vertical directions. Sometimes two mirrors handles can be used to achieve the same result. And increased tooth mobility is usually a result of advanced marginal periodontitis, but can also be caused by acute apical periodontitis or severe occlusal interference. In the case of a root fracture, tooth mobility may also be increased. Clear increase of vertical mobility has been traditionally regarded as a sign of poor prognosis. So it was main methods of examination, visual examination, percussion, probing and palpation, and checking of tooth mobility. And now we discuss extra methods of examination. The most widely used method it is called a temperature test, cold-hot sensitivity. In a cold test, the cold object is placed on the crown on the tooth near the gingival margin for best performance. Several teeth must be tested for proper reference. The cold test can be performed with an ice stick, ethyl chloride, or frozen carbon dioxide. A negative response to cold may be an indication of pulpal necrosis, but this is also influenced by other factors such as the amount of secondary dentine. The heat test is usually performed with gutta percha that is warmed with a flame and then pressed with an instrument against the tooth surface near the cervical margin. Excessive heating must be avoided to prevent damage to the pulp. So, negative test result may indicate pulpal necrosis, but if tooth respond to heat, it means that this tooth is vital. The same with the cold test. Electric pulp test. Electric current from a pulp tester is used to stimulate pulpal sensory nerve endings. The tooth and its surroundings are air-dried and isolated from neighboring teeth with the plastic strips. And then the tip of the instrument is placed directly to the incisal edge or to the cusp if it goes about molar, and press on the button for working mode, and patient is informed to indicate when he or she feel a pain sensitivity, and then the tip of the instrument should be withdrawn. And dentist indicate the level of pulp excitability, and thus can estimate about the process of inflammation, because the more inflamed pulp tissue, the less it is susceptible to electric stimulation. X-ray. Bite-wing radiographs are relatively reliable for detecting interproximal lesions, but less so for occlusal lesions. Radiolucencies developing below the contact areas appear like horizontal V-shaped notches in enamel-only lesions. As the lesion progresses into dentine, a mushroom formation occurs as the enamel appears to be undermined along the enamel-dentine junction. Caries detectors. It is an excellent means of detecting caries and plays a major role in maintaining and preserving teeth. It provides support for the excavation of the demineralized outer tooth structure affected by the caries, making it possible to remove the caries as completely as possible. At the same time, it makes sure that as little healthy dentine which can be remineralized is removed as possible, secures pulp vitality and preserves the healthy tooth structure. The technique of applying caries detectors is such. Firstly, it is necessary to prepare the caries cavity and then apply disclosing agent. And after wash it with appropriate amount of water, and that areas that is discolored considered to be necrotic and should be removed excessively. And here you have the final view of the cavity after cavity preparation. Instrumental methods of caries detection. Conventional methods of detecting dental caries include manual probing and radiographic evaluation. So here I have highlighted these techniques of how to detect the dental caries. But although these techniques are effective in detecting advanced stages of decay, they are ineffective in detecting early dental caries. With the advent of laser detection techniques, dentists can detect early dental caries and provide patients with a non-invasive or minimally invasive approach to clinical management of dental caries. And Diagnodent caries detection laser. It is a portable battery-powered diode laser. It causes active caries to fluoresce. The amount of fluorescence is measurable and is correlated to the size and direction of the lesion. Here you have the cases in which the Diagnodent device can be used. It is class 1, 5, and incisal caries, class 3 and class 2 lesions when used with the visual examination, X-ray, and transillumination. Laser caries detection can also be used intraoperatively to check minimally restorative preparations for complete decay removal and helps in decision-making process to restore or not to restore. This is transillumination. This is a rarely used technique to assess caries on molars and premolars, but more commonly used on anterior teeth. Direct light reflected by dental mirrors onto the teeth can highlight darkened shadows present between the interproximal surfaces of upper anterior teeth. A caries lesion shows as the darkened shadowed area in dentine surrounded by a normal colored zone. Light curing lamps can be used to examine the surface as white intraoral lights are not common. These lights need to be directed between the contacts of teeth and have sufficient intensity to show the caries. Generally, ambient light sources need to be reduced to improve the reliability of the diagnosis. And here you have the photo that shows how the tip of this device is applied to the tooth surface and visible defect, caries defect. And the same is here. UV light is directed to the tooth surface, and here is visible interproximal lesion. This area is darker than other areas of the tooth surface. And diagnostic tool in endodontic, laser Doppler flowmetry. It was developed to assess blood flow in microvascular systems, but is now also being used for diagnosis of blood flow in the dental pulp. So for this procedure is used helium neon and diode lasers at low powers of 1-2 milliwatt. And technique is such. When the laser beam is directed through the crown of the tooth, it passes through the blood vessels within the pulp. The moving red blood cells cause Doppler shifts in the frequency of the laser beam and backscattering of some of the light out of the tooth. Use of lasers for pulp sensibility testing offers the advantage of not relying on a painful sensation for diagnosis. And final statements about documents that are used on the dental reception. In Ukraine, such documents are mandatory for dental institutions. Application form number 037. It is card of daily dentist work, where dentist should record all patients and all possible and all work that was done to this particular patient. Next, it is medical card of the dental patient, dental chart, application form number 043, and application form number 039. It is monthly journal of the dentist report, the final report of the dentist work for a month. Propose to you such summary points of this lecture. A complete examination covers the following three areas. The first, general examination, briefly assesses the patient's general appearance. Next, extraoral hand and neck soft tissue examination focuses on the head and neck, and intraoral soft tissue examination determines if the soft tissue is within normal limits. And in conclusion, it is worth to say that any diagnostic procedure for the diagnosis of caries tooth structure must be specific, valid, reliable, and clinically proven. References that were used for this lecture are such: diagnosis and treatment planning in dentistry, treatment planning in dentistry, and dental diseases differential diagnosis. These books can be recommended as a further reading, as they are available in a free access online. Thank you for the lecture and have a good day.